Welcome to the Crackenbacks podcast. Today we're joined by none other than the famed cardiologist and tech maven Dr. Jaime Murillo. Ever wondered where the heartbeat of AI meets the rhythm of cardiology? From his groundbreaking collaborations with IBM Watson to the future of wearables in predicting your next heart flutter or medical condition, Dr. Murillo has the pulse on it all. As the world buzzes about the rise in cardiovascular conditions post-COVID, get ready to hear insights straight from the heart of an industry innovator. Dive into an episode where innovation, health, and future intertwine. Dr. Murillo, finally getting you on our podcast, man. It is not only an honor, but I'm so excited to talk to someone that's at your level of healthcare, of your level of understanding of artificial intelligence and all that. Thank you for being on the show, man.
No, my pleasure. And you're talking about you being at my level? Is that what you meant?
No, he's talking about he's been having to deal with my level, which is so low for so long. He's finally feeling good that he can actually talk to somebody intelligent.
Oh my God.
Oh my God. Yeah, that's basically.
No, man. Yeah. In all seriousness, it's great to be with the two of you. And I was going to say two of us.
Yeah. Oh, sorry, Terry.
That's okay. I'm used to it.
Oh, man. Well, listen, you have a truly unique background combining cardiology with computer sciences, and now, artificial intelligence, AI has become such a household word. Can you please start by sharing with the audience how this fusion has shaped your career and approach to healthcare?
Oh, that's a big question that we can talk about for a while. But I mean, I think one of the major limitations on healthcare, as great as it is that people don't get healthcare right when they need it. And that's where technology and AI can make a difference. Now, can we say that we're ready for that? I would, without hesitation, answer no, we're not there yet, but we have made a lot of progress. There's a lot of hope, but along with that hope, there's also that caution of, be careful what you wish for because AI can do a lot of things. And I think as excited as we were when we started with this wave of AI in the healthcare space, we're now starting to find out that we have to be even more cautious than we thought we were going to be. So the bottom line is probably one of the areas where AI can make the biggest difference is healthcare. There's no question about it. So a lot of things could happen, and also ultimately end up in providing that personalized care that we really all aim at. Because as you know, today we have a good prescription for millions of people, but the reality is there are not two single human beings who are the same. So we should all have our individualized treatment. I think AI will help us get there and along the way.
Before I got on the show, I was just rifling through emails and I saw something about that AI, they're using the technology to identify, they're looking at retinal photographs and being able to accurately identify conditions that would typically be more subjective when looking at through an ophthalmoscope. It's fascinating what AI can do, but I'm sure you're embarking on a lot of different things, but as someone who's spent years in both the clinical practice and executive roles, tell us about that pivotal moment that inspired you to transition from, surgery, radiology, clinical practice to healthcare leadership.
It was more of a series of events that led me to think that we need to do something different. And in a selfish way, and that's what the Dalai Lama calls why selfishness. I remember one day when I thought, what if I 75, 80 years old, and I'm going to ask myself, what do they truly do for the people, for society, for healthcare?
Wow.
And I don't want to end up my days practicing cardiology thinking that I didn't do enough. Oh, you could argue, well, as a cardiologist, you could save a ton of lives. Yes, but still doing practice in healthcare in a way that I know is not optimal. So I just decided that it was time to leave that practice, embark on a different career, and be able to innovate. Actually, I'm almost embarrassed to use the word innovation. I rather use the word simplification because we have made such a mess of healthcare that all we have to do is just simplify it. And if we simplify it and with the people in mind rather than the healthcare systems or the providers in mind, then I think we all gain, including the providers who are so overwhelmed and burnt out in many occasions. So my journey right now is, can we simplify healthcare? And technology is what is going to help us.
Yeah, I love that. That's great. Terry, do you notice that he's looking at the potential for helping more people? That's kind
Right.
of like what our show is about, and that's
Right.
what
Exactly.
Dr. Terry originally was driven to do with this show. So thanks for being a part of that consciousness. You know, it's this is such a perfect time to talk to you about technology because it's blowing up right now.
Right.
Everything about life is AI, and I want to know more about IBM Watson on machine learning technology development. I mean, how do you use AI to be revolutionizing the healthcare industry, especially in the context of cardiovascular disease?
There are many ways. That's a good question. And the way I see AI contribution is in waves. So let's start with what is the safest way to do it and then move on to what could be changing. And I truly believe that we will redefine the concepts of diabetes, hypertension, and so many other conditions. Because right now, think about how we see those conditions is in a binary form. Either you have diabetes or you don't have diabetes. Either you have hypertension or you don't have high blood pressure. And that's because we use a single cutoff number, right? That's it. Is
Mm-hmm.
that simple? That's very simple, but that's not accurate because, again, as I said before, all human beings are different. It's just the same way the color scale goes from black to white, and along the way there's millions of different um, variations and gradations. Healthcare is the same, and a person is the same. So eventually we'll get to that point. But let's start with what we're doing today. So we're doing things like automation. So you mentioned looking at images, for instance. That's fairly easy. I mean, today looks easy. 10 years ago it didn't. But if you have patterns that the computer can recognize, looking at the eye, the back of the eye, the retina, looking at electrocardiograms, looking at chest x-rays, looking at CT angiograms, the computer, one, doesn't get tired ever. Secondly, it can work 24 hours a day. Third, it will pick out things that a pair of tired eyes at 6 p.m. and they may miss. So I think it will give us more confidence to diagnose things that we may have missed and diminish or decrease the amount of potential human errors that occur along. But at this point, it's serving as a tool to aid doctors and other providers make that diagnosis. So let's not think that machines and AI will replace what doctors do today. They're essentially serving as a tool that will help us remember things. For instance, the other area where there's a lot of progress is what we call CDS, the clinical decision support. Clinical decision support is like having someone right at bed next to you that says, hey, the guidelines change, and now instead of using X medication, it's better to use this other medication. Oh, hey, this person has a function in the kidney that requires that medication you're going to provide should be titrated. Give it a different dose, a lower dose, and so on. So having that super memory next to you in front of or in your computer, it will make you better at treating people. So those are, say, things that we can do today. Automate tasks, a lot of tasks, they require a lot of repetition that you don't need a doctor for that. But the doctor will supervise every step of the process. And then we can start thinking about what else is in the horizon that we could do that I just alluded about, eventually redefining disease as we know it today.
Tell, you had mentioned like maybe last year or something about how does AI and whatever technology you're working on for diabetes, how is it being able to diagnose better or treat better?
Yes, that's one of the areas where there's a lot of technology. And I know I've been talking about AI, but think about digital technology, all the wearables that we have, and then how technology. One of the areas that I think is most exciting is how technology can actually change behaviors. I'm going to give you an example. As part of the work that I do, I get to wear a lot of gadgets. Or right now I'm wearing one that this ring in my
Yeah.
finger is
Yeah.
checking my blood pressure, my heart rate, my saturation of oxygen, my rhythm, all at once, and I can see it all in an app in my phone. So last year I had everybody has probably heard about the CGMs, the continuous glucose monitors.
Yeah.
So you just stick it in your belly. It's very easy to put on, and it will check your sugar level every 5 minutes. And one day we were at a tennis tournament, and it was time to have lunch. So we went to shop, I mean, a store, a fast food restaurant, and we had to leave. So we just said, I'll just get in, grab a sandwich, and then we just eat it in the car. So I went in, and my wife said, hey, let's just grill cheese. We'll do the job. So I wasn't too hungry. So let's just get one, split into two, and okay. And so I went in, ordered a grilled cheese with whole wheat, and went back to the car. And when I opened it, I realized it was white bread grilled. And I said, well, so we're just going to have half of it. And I ate that half, and all of a sudden I see my sugar within half an hour is 180. And I'm like, oh my! I mean, the things that you start realizing that you do with your life, not knowing until you have some data to show right in front of your eyes. I can tell you, I was like, I'll never have that grilled cheese ever because I know what it does to my body. Not everybody will respond that way, but I mean that was that twice as high as a normal sugar level. So those are the kind of things that change your behavior and make you think. I became more conscious about what I'm putting in my mouth after that experience. So I think digital technology really can help not just to say for the doctor to say, okay, I see your sugar is doing this and this, but for people actually to see what is the actual response to any event. It could be a stress, could be exercise. I do Pilates. You know when my sugar was the lowest during those 24 hours when I was doing Pilates. Somehow I was in the zone and my brain was allowing my body to just control that sugar level. I was surprising to me. As much as I know about how the human physiology, I was shocked at how the brain can really have these powerful effects.
Hmm.
This is great. Now, you don't have diabetes. You're just using this as a well, part of because it's part of the project, but I mean, you're using it to see proactively man, I didn't even think about that. How
Mm-mm.
fascinating.
Yeah, that's cool.
Food affects you in ways you don't even know.
It does, and even for a person who's not like he just said something that is very important. Look at healthcare, how we practice healthcare today. We practice healthcare in a way that we wait for people to come to us with a problem. So someone may have, hey, a pain in the chest or shortness of breath, tiredness, fatigue, blurred vision, whatever. And they go to the doctor and the doctor says, okay, let me examine you and treat you. But can you imagine the amount of people that are walking around with conditions that are not necessarily manifested yet? High blood pressure is a perfect example. Diabetes is another one where you can have that condition for years and not feel anything. So is there now you have to ask yourself, is there an opportunity for us to be more proactive and maybe find signals that tells us that that person has a condition that we need to address now instead of waiting until they develop a symptom or a complication. I mean, I can tell you that many times the first time someone finds out that they have high blood pressure is when they go to the ER with a stroke. That's sad, right? But
Yeah.
it's the reality. So, can we actually do that? And I think technology could be at a point where eventually will be cheaper to put those signals, whether it's active or passive. There are signals now at home that could analyze how you're sleeping without putting anything on your body. You can have sensors in the ceiling
Oh
that
my
can see how your chest is moving,
God. How cool is
and
that?
then they can tell you whether you have moments of what we call apnea, which means you're not breathing. That means you have obstructive sleep apnea, which is a condition could lead to high blood pressure could lead to lung disease, could lead to rhythm problems. So it's fascinating just to think about all the things that we can do with technology.
So when you say wearables and continue and monitoring like blood pressure or heart rate and so on, you also like the ones that polar but polar or something go across the chest and you have a watch that picks up.
I've seen
Or is it?
those, and yeah, they monitor your heart rate and so on. So there are a lot of things. I mean, there are a lot of different gadgets out there. What we also have to be mindful of is one is they can do a lot of good things, but that's not translating to benefit, both in quality of life and prevention of bad outcomes. So I think that's where we need to prove that it's important to wear those because right now the investment in those gadgets, is it cost effective? Nobody has an answer yet.
Hmm.
On the space of diabetes, I think people are saying, well, if we have those continuous glucose monitors on, we may be able to compensate by treating people earlier before they spike their sugars and sustain spikes for too long, and maybe prevent damage to the kidneys and cardiovascular disease, as we know, is the main cause of mortality among diabetics. So there are spaces where I think we can justify that spend, but I wouldn't right now jump on putting yourself on 10 different gadgets in your head, your fingers, your wrist, your chest, everywhere, just because it's cool. And actually, I have to admit, for those who likes gadgets, it's cool, but does it really translate into real benefit? That's what we still need to find out.
Okay, you bring up a good point there. At what point does technology disempower somebody, or where it becomes maybe overwhelming, or they become hypochondriacs, or something? What is? Do you see a downside to that at all?
Yes, yes, we should discuss that because we get excited about it, but the downside, we just mentioned one of them, right? Are we spending more than we should just because it's there? Number two, is that a cause of anxiety? It's funny you should say that because I've been wearing this ring, and sometimes at the beginning I was like, it has the ability to check the blood pressure whenever I want. And I was like, I think I'm checking my blood pressure too many times a day. I shouldn't do that.
Right, right,
And
right,
then, as a cardiologist, I remember, those who worried a lot and they brought me all these, like, pages and pages of blood pressures, which I love that they're, in tune with their condition, but not to the point you actually end up. They were like, "Oh, my blood pressure was a little high, so I checked it 5 minutes later, it was higher. Then 10 minutes later, it was higher." It's like, yeah, because you're stressing out with that blood pressure.
Oh,
Right.
that's
so,
right.
so yeah, there's a downside to that, but so that's part of the work that we need to do is how much is too much, and how little is too little. But get to the point where there is a balance in between what we want to find out and then have someone that we can trust that will be with us, telling us, okay, this is the right way to do it, or let's just do it, back up a little bit here. But thank you for bringing that up because it's true. For some people, it can be actually a source of a stress when it's like, oh, my heart rate is what? Oh, no, no, no.
I mean,
That's
if
great
you put this
because it's funny. Oh, sorry.
wait, if you put this technology in somebody like OCD, it could be detrimental, couldn't it?
Yeah.
Yeah, it could be. By the way, I'm so glad Dr. Terry just spoke because I felt that Dr. Barron was not letting you talk at
Oh,
all.
sorry.
So,
Yeah. See, I
It's
told you. I
true.
told you.
All right.
no,
I'll
no,
shut up. I'll shut
I'm
up.
just kidding. But yeah, so someone with OCD, yeah. But again, that's where you need someone, a team, right? That you can count on. Is in the team. That's something that we haven't talked about it, but I always preach about the need for a person to have a team caring for them because I mentioned earlier, doctors are overwhelmed, burned out, and we expect that doctors are there to answer every single question and be available 24 hours. And unfortunately, the reality is that just mathematically it's not possible. So having that person who, let's say the doctor says, hey, I want you to wear these to see, make sure the rhythm is okay. That's something that we use today in today's practice. And that person is checking that and so on. they may have a partner within the doctor's team that will be able to check that for the patients and reassure them and say, no, no, you don't need to check it that many times. So, we know that if you check it twice a day is enough, or twice a week is enough. So having that, that team, and not letting people just worry about themselves without having any guidance, because the information is good, but it's not about what you see in front of you, is interpreting the right type of information to really help people.
You know,
So thank you for that question, Dr.
well, on that topic, with your knowledge of cardiovascular disease as well as AI, at this point, because it's only going to get more. I mean, it's not going to get less, right? We're going to get better at AI, and it's going to get more wearables. We're going to get more information. We're going to get. It's like when the cell phone first came out, we thought it was going to make everybody's life simpler, and it made everybody's life more complicated. So, at this point, what is your strategy when you tell somebody that is going to be all about the technology and watching every 50? What is your strategy that you tell people now?
So the strategy is the following, and it's very simple: is find the right technology for the right group of people. And I'm going to illustrate that with an example. And I'm telling you, what I'm telling you is public information. So you may remember that Apple did a study to assess whether the Apple Watch was good to detect atrial fibrillation. And atrial fibrillation is an abnormal rhythm of the heart, where the heart goes irregular. And instead of boom, 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 it goes like boom, 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 boom. So that irregularity leads to the blood. Imagine the blood inside the heart shaking all over the place. It's like you're shaking a milkshake. So that shaking of the blood may cause some clots to form inside the heart. And those clots may be pumped out when the heart pumps the blood out to the rest of your body. Some of those clots may go to your brain and cause a stroke. That's the connection between atrial fibrillation, the irregular heartbeat, and the stroke. So the idea is, if someone has atrial fibrillation, we need to thin that blood out so clots will not form, and therefore has been shown to prevent strokes. So right now, the idea is, how can we find people who have atrial fibrillation that they don't know that they have it? Some people may have some palpitation, but some people may feel nothing. And find those people and then give them blood thinners so we don't have a stroke. So it sounds really good, right? Well, what happened next was that there was this number of devices that are now in the market for atrial fibrillation assessment. And what we have recently found out is that we have found more atrial fibrillation than we knew of, not surprising. And when they go to the doctor and said, hey, I have this device, and this device says that I have occasional episodes of atrial fibrillation, the doctor does what the guidelines recommend. Well, I'm going to put you on blood thinners. So fortunately, what's happened is there are a couple of publications out there showing that the more people on blood thinners, what is the other side of the risk? Bleeding, right? Mm-hmm. If your blood is thinned out, now you're more likely to bleed. So are you more likely to have a stroke or more likely to bleed? That's what the doctor's decision has to be made. And there are scores. Has-Bled score is one of them for the risk of bleeding, and then the other is called CHAD score to assess the risk of a stroke. But it's not always easy. So what that tells you, Dr. Terry, is that now you have, we have to be very cautious about putting that technology in the hands of everyone, because maybe that's not the answer. Maybe some people have those episodes of atrial fibrillation, but they don't mean anything. They don't necessarily lead to stroke. They're not bad enough. And then we put in blood thinners. What we're doing is actually changing their conditions and causing bleeding that sometimes can be fatal if it's in the brain or GI, the gastrointestinal bleeding. Or even trivial bleeding. Nobody wants to have excessive bleeding. So we have to be very mindful that technology is not actually causing harm, is the bottom line. And I think we now have a better idea of what that means, but I would say there's still more work to be done in that regard.
Wow.
Well, since you mentioned it, you mentioned strokes, and I know Dr. Spencer and we've been seeing such a huge, in the last, I don't know, a few months, 6 months, a year, a huge uptake in myocarditis deaths. I've seen more TIAs and strokes in the last probably 6 months than I probably have ever seen or heard of. What is your perspective on this increase and why it's happening?
Alrighty. So you mentioned myocarditis. So the myocarditis at this point, there has been some association in a minority of the cases with COVID. COVID is unfortunately, I was going to use the word fascinating, but it's not fascinating for those who had COVID and have sequela. But it is an intriguing and unfortunately challenging condition because we all thought that initially that COVID was a problem with the lungs, right? We think of these kind of infections, flu and respiratory syncytial virus as being related to the lungs. So we thought if you have lung problems, you're more likely to have COVID. If you have COVID, it's more likely to affect your lungs. Well, guess what? Well, we found that it was the people who are at high risk were those who had cardiovascular conditions, high blood pressure, previous heart disease, heart failure, previous heart attacks, and so on. And then obesity, which we know obesity is tightly close to cardiovascular conditions and lung disease to some extent. And then after they had COVID, now we see the surge of conditions that are probably associated with two phenomena within the body. One is a pro-inflammatory effect, so it causes diffuse inflammation, and that inflammation at the same time in turn leads to clotting. So we see this small disease, this tiny arteries clotting there, and that affects organs like kidneys, heart attacks, TIAs. For those who don't know, transient ischemic attack, that means that the flow to the brain is compromised, by definition, less than 24 hours. But that could also be indicative of potential stroke down the road. So that's what we have seen. And the myocarditis is part of the inflammation of the muscle of the heart. So, but the degree of inflammation goes to the discussion that we had before. Is it clinically significant? In other words, is it bad enough that will cause you to have sudden death? Like, and we've seen some of them because the inflammation is in the entire muscle of the heart or the majority of it. Sometimes it's just very small areas, but they don't. The heart keeps working fine and eventually heals and it's on and doesn't leave any residual. So that also leads us to think: should we do an MRI on everybody just because they have COVID? The answer is no, because most of those cases are not significant and they heal on their own. The other piece of answer that I have to your question that is even more concerning is heart attacks, strokes on the rise, but not because of COVID, but because of our lifestyle. Because especially in the US, unfortunately, I don't know if you're familiar with those statistics, but we had a 50-year decline in heart disease related mortality. And over the past 12 years, it's gone up. And if you look at compared the report from 2022 to 2023, you see a steeper upward trend of that curve. So the question is why? We did some work around that, and we found that strokes and heart attacks, especially heart attacks, is where we looked at in more detail, are rising among the younger population, and usually ages 35 to 64. There was a high, not necessarily majority, but the rise was more significant among the Black population. And here this, which is astonishing. We always thought that women were protected from having heart disease. Guess what? That protection seems to be going away because we found that 48%, almost half of the heart attacks in the Black population were females, women. So why is that? Well, because the proportion of obesity is going up, because high blood pressure is going up, unfortunately, because diabetes is going up, and all the conditions related to diabetes. Smoking, which we also found that smoking is going up. Who thought that I thought smoking was going down. It's actually no, going up. So we have this younger population having diseases that in the past were diseases of people, older people. Like we always thought that heart attacks were typical was white, elderly, all great, older than 65, I have to be careful now with the use of the word elderly. Older than 65, male smoker, right? So now you're laughing. So, but no, that's not the case. That actually is decreasing in that group. So we ourselves, I think we're doing something wrong. Whether it's sedentary lifestyle, whether it's the stuff that we eat. I mean that grilled cheese example.
Mm.
I was thinking because I actually saw my own sugar, and I'm going to be very put myself in the spot. I noticed over the past 2 years, you asked me whether I was diabetic, Dr. Barron. I noticed over the past 2 years my sugar was going up, my hemoglobin A1C, which is a marker of the sugar for 2 or 3 weeks.
Mm.
And I was puzzled because I don't have a history of it. I exercise on a regular basis. And
Mm.
last time I found that it was right in the pre-diabetic range in February, I thought, okay, I need to make a change here. So I stopped bread, pasta, rice, and stopped nibbling in those chocolates around the house. And within 2.5 months, it dropped 4 points, which is massive. If you're into diabetic, you know that if you drop 2 points in a year, you're lucky. Well, I dropped 4 points, completely normal, just making a lifestyle. And I was thinking, if I'm an educated person and I have relatively healthy lifestyle, no wonder we have such an epidemic of disease in our country because people don't know what they're putting in their mouth. We just don't know it. So we have to be, as a society, we have to be. I don't use the word education every single time because it gets you so far, only so far. But we definitely have to be more mindful of what we're doing with our life. And I feel now I'm finding myself preaching and not letting that just spin so that to Terry talk. But I'll stop there.
Well, listen, I'm compelled to ask you in retrospect to what Dr. Terry asked. We do see some research that's published that there's a relationship to myocarditis and the vaccine. Do you have any comment about that, or would you want to share?
Well, I mean, what I know in terms of the vaccine, and we have done some work on the R&D space, there's not a demonstrable correlation between vaccination and that. We know for sure that there's a correlation between COVID and inflammation and clotting, as I mentioned to you. So you find sometimes some isolated reports. As a researcher, I'm very picky about the data sources, how clean the data is, what is the number of people that were studied, is that a true representation of the population? What other factors are what we call confounding factors? So sometimes we make associations between one thing or the other, but it turns out that there are other factors that explain that outcome and not necessarily what we initially thought was the association. So I would say that I will be more cautious because we know it's almost like you in that position of vaccination, no vaccination, and we all have the right to disagree on what's the best thing to do from the population health standpoint. When you talk about not just one person but talk about millions, I think we have proven already that vaccination does the job better than no vaccination. But I'm not going to say that it's like taking an aspirin, right? How many people take aspirin in this world? Well, guess what? What we're finding now is that aspirin is not as good for everyone as we thought, right? Back in 1989, there was a study called Physicians Health Study, and they followed doctors from the Harvard Medical School for many years, and they put half of them in aspirin, and they found that aspirin was preventing some heart attacks and strokes. So they thought, well, everybody should be on aspirin. And then we put everybody on aspirin. And then we find out that we have a lot of bleedings because aspirin was causing damage to the stomach and the intestine. So now we're saying, oh wait, aspirin only for those who had a higher risk of having a stroke or a heart attack, not for everyone. And with the vaccine, I think we may eventually find that maybe for certain people who are at a high risk of the effects of COVID and what COVID can kill them and or cause serious disease, maybe it's not for everyone. And right now you've seen the recommendation. Well, if you have a condition that affects your immune system, if you're older than 65, that may be the group. So, but not necessarily for everyone. But thank you for asking, because I know it's in the mind of many people. It's like, should I or should I not? But I think if you're in that risk category, you should.
My only concern, I'd love to hear your thoughts on that, is that we are all trained, whether you're a chiropractor, a cardiologist, internal medicine, pediatrician. When a patient comes in, whether they're feeling good, so it's more for prophylactic measures or maintenance or what have you, or they're coming in with a condition, we're all taught to do a consult, a history examination, and then make treatment recommendations. And that's the only reason why, you know, to reinforce what you had just said about some people don't handle aspirin as well as others. But that's, I guess, how I look at the vaccine. It's not a perspective that should be given globally without doing without doing some sort of thorough background or determination that, can you even handle this one size fits all approach? Your thought on that? Is there?
Well, I think that's what that these are the tough decisions, right? Because we know that in order to put a drug in the market, you need years of research, and you go through phase one, phase two, phase three, phase four, and then only when we demonstrate it's safe, then we said, okay, now it's ready to go to the market. With vaccines, there was no such a time, luxury of time, and the decision was, well, we need to develop something quick and save people's lives because we don't have time to wait until the data is. I think we're at a point right now where we have accumulated a ton of data about vaccination, COVID, having data, ideally data on those who were not vaccinated versus who were vaccinated, and then follow up over the time 6, 12, 18 months, 24 months, and see what happened to those people, and then start doing some analysis around that. And that's how we can have, at least from the real world experience, that's how we call it, instead of a typical randomized clinical trial where which means you have a group and then you assign half of them to the treatment and half of them to no treatment, what we call placebo, and then follow them. In this case, it's more of a real world experience. What happened after we put this in the market, and learn from it. So it was a tough decision. If we don't do anything, I think most of us will agree more people would have died. But so we had to make that tough choice, or they have to make that tough choice of saying we need to vaccinate. But I think now, 2 years later, it was March 2020, 3 years later, really, 3.5, we are at a point where we have enough data to start making inferences. The NIH, the National Institute of Health, is conducting what they call a long COVID study, trying to figure out what are the sequelae of COVID. We know there are people who are still suffering from long-term effects of COVID. So what can we do? What is different about that group of people that could have caused that? And could a vaccination prevented that? Or equally, those who got vaccinated, did they actually avoid those complications? Or they actually also, there's a group of them who had complications as a result of the vaccine. We don't know that entirely for sure, but I think I expect that we'll see enough data coming out in the next few months.
Thank you.
Thank you very much for that. That was perfect. Switching gears a little bit, what's your feeling of HRT? So hormone replacement therapy, especially for women, and the effect it has on the heart. And have you seen the addition of AI as an advantage in monitoring this condition, and where you see that?
Well, let's just talk about that for a second. So we talk about, and I alluded to the fact that we thought that women were protected from heart disease, and that's why women tend to develop heart disease 10 years later than men. So the risk of a 65-year-old woman is the same risk of a 55-year-old man. That was kind of the story that we thought. And then we said, why younger women are protected and all the women are not? And the thought was, well, maybe because there's a hormonal change. So then they thought, what if we put women in hormone replacement therapy, and so they can continue to get that protection against strokes and heart attacks. And there were some controversial studies. Some of them showed protection. Some of them said, well, we actually may be causing more damage, especially clotting in the veins, on the arteries, or even in strokes and so on. And so that study has been that field has been very well studied at this point. There are plenty. Another study is called the Nurses Health Study, also done at Harvard, has been following women for more than 15 years. And besides that, there are other cohorts where this is what they found. If you start the hormone replacement therapy several years after women became postmenopausal, you're introducing a significant change in that woman's condition that may not be good for that body.
Mm.
But if you introduce the hormone replacement therapy right when they're going through that menopause period, you're essentially continuing the same dynamics and same hormonal level that the body had for those years before, and that risk is lower. So they are already compare those who received treatment around that period of time, those who received treatment later on. They found that there was a significant difference. So now the advice is, if you've been out for 5 years and have hormone replacement therapy, yeah, we definitely need to think about putting you on that replacement therapy. But the risk is clearly less. When you compare premenopausal to postmenopausal women, there's a significant 2 to 6 fold increased risk. So the idea is, yes, hormone replacement therapy, as long as you started right when it's right and not wait too long. I hope that helps you clarifies the story. AI at this point, I mean, that's because it's more clinical. The only thing I can think, the only way I can think of AI, and this is more futuristic. There's some ongoing work, but not ready for prime time, which is the work on proteomics. So in proteomics, you can imagine now. I mean, this is a fascinating area.
Yeah, yeah.
So the body makes 150,000 proteins every day, right? Because you need your thyroid working fine, your kidneys, your liver, and so on. So you have the genetic makeup for how proteins should be made, and you also have your lifestyle, your stress level, your exercise activity, and the diet, what you eat. All that influences what your body makes on a daily basis. So it's fascinating that that 150,000 proteins. So we only know about 10,000 of those, that we have the actual composition of that molecule to be able to measure it in blood. So let's say, Dr. Terry said, hey, Dr. Terry, give me a sample of your blood. I'm going to look for your proteins in your body, the ones, at least the 10,000 that we know, and see how you're doing. And they'll find out that they can tell how your liver is doing, how your kidney is doing, whether alcohol is affecting your body function. Maybe you don't want to find that out. Whether your exercise, what's your exercise capacity? What's your daily calorie intake that at rest? How much calories you're burning at rest, and so on. So that allows you to you can even what's your fat mass in your body? What's your lean weight? What do you have fat in your or internal organs? I mean, there's fascinating amount of things that we can find out. So now that's when you start talking about personalized approach, right? Because then let's put in the example of this postmenopausal woman. If they said, okay, we look at your protein. I haven't seen work in that regard, but I bet there's someone working on that. But it's fascinating just to think about the application, because they may say, based on your protein pattern, you definitely need replacement of more progesterone or more testosterone. So you can really personalize the approach based on those measurements. So that's where but proteomics can only be assessed with AI, because there are millions of data points that imagine you have an Excel sheet in front of you. It's like, there's no way I'm going to look at 10,000 proteins, for everybody and so on. So that's where AI can have a role. And there's something called machine learning, where you can actually analyze, thousands and millions of data points, and the machine will learn based on that. What are the patterns that a human cannot recognize because the data is so massive. And they may come out and say, you know what, when it comes to diabetics, we have this proteomic pattern here, people who have certain elevations of certain proteins, and there are other diabetics who have a different elevation of different proteins. Maybe we should treat them differently. It's not just about lowering their sugar, right? It's more than that. So that's why I say it's more futuristic, but that's a fascinating area. The proteomics series, I think it has a lot of potential in the future to personalize care. Right now, they're doing a lot of the proteomics. There's also genomics. So there's a lot of work going on about, what is the right medication you respond to? And so let me take a sample of your blood, look at your genes. It turns out that I have two potential medications that you could benefit from, but you're going to respond better to medication A than B. So I'm going to give you that one. Instead of giving you one and then wait to see whether it works for you or not, and then try the other one.
Wow. That's cool.
Is futuristic.
Cool.
Yeah, I love that. All right. Now we're really going to switch gears and we're going into one of our favorite areas of our podcast, and that is our rapid fire questions. These are questions we ask you, give brief answers, but as I always say on every single podcast, we end up getting hung up on something cool that you say and we start talking about it. So we'll bring it back to rapid fire.
Wait,
I'm going to do my best with those. I'm very cerebral, so it's very hard for me to do that rapid fire because I'm not extinct. I have to think everything. Go ahead.
And you notice how he said we?
You ready?
No, he gets all wrapped up.
Yeah, that's basically right. All right. Question number one. Since we were talking about IBM Watson, and besides that machine winning Jeopardy, tell me something that most people don't know about IBM Watson.
People are very caring, actually. That you think of IBM Watson as people who are just dedicated to technology and nerdies and so on. There's a lot of people who really care about doing it for the right reasons for people to get healthy.
All right. Number two, what is your favorite book to read when you're on vacation?
Anything has to do with drug dealers, mafia. I love that stuff.
I love mafia
books.
It's
all very intellectual.
That's awesome.
That's because all day he's all techie, and then he needs an escape.
That's awesome.
Yeah. So you must love The Godfather and Scarface.
Oh yes, I still watch The Godfather from time to time.
I would have never thought that. That's hilarious.
A man of my own heart.
Right. Question number three. All right. Besides the Terminator, what AI movie or something that uses artificial intelligence do you feel is really a true or more truthful glimpse at the future?
The Matt Damon, what's the name?
Which one?
He has a series.
The Bourne Identity.
Yes.
Yeah. Bourne Identity.
Yes.
Jason Bourne.
Yes. Yeah. Yes. Fascinating.
Oh, that's one of my favorite. I love those sequels. Great.
Yes.
All right. What is something about you that even your friends would be surprised to find out about? Other than mafia and drug dealer.
They are surprised about me that I'll give you a fun fact. I'm a lord. You're going to laugh at this one. So it turns out that for my birthday, my wife gave me this title that I'm a lord in England. And I was like, wait, how does that work? So it turns out that by English law, if you buy a piece of property in England that is part of the lordship, you actually are entitled to change your name and be lord. And so this is a nominal. So obviously, became a business because now you can buy a nominal portion of that land, and for $150 you can become a lord.
No,
I am so doing that.
don't tell us after the show is over where we can find this, because you see where it says Dr.
Lord
Terry on
Spencer, Lord
right,
Spencer.
right.
I am good, and then we have to make our wives call us Lord.
Yes.
I don't think I have told anybody, so you get the.
Oh, I can't wait. I think I want to make sure our engineer David cuts this section out so we can monopolize on it. So we can monopolize on it, and then we'll re-release it with it. Once we become Lord Terry, Lord Terry.
Yeah, we're gonna have to put on our byline Lord Spencer and Lord Terry's podcast.
Oh,
Yeah.
Okay, I'm contacting Christina, and I'm
Okay.
going to find out all the details. About that is the coolest thing I've ever heard. I love. Oh my god! All right, I don't even want to continue. Okay, no. Question number 5, last one. Most memorable moment as a doctor that you knew you were in the right profession.
The moment that I saved a life after working on that person for 5 hours.
Oh,
Someone
my
who
God.
was 46 years old. I mean, I knew I was in the right profession, but that moment, it's one that I'll never forget. I had already been in practice, and this woman came with a heart attack, only 46 years old, and pretty much dead in the emergency room. And I took her to the cath lab, which is where we go, inside the arteries of the heart, go through the groin, inside the arteries of the heart, and try to figure out what's wrong. And she had a massive clot inside one of the arteries. But we had, even before that and during that, we had to resuscitate her, you know, chest bumps and medications and connected to the respirator and shocks. I've never shocked so many times one person in and we insist. I mean, it was fascinating because she will refuse to go away. I mean, to just say, I want to live, and we just kept pumping, and we normally would you give up after 20 minutes, but she kept giving signs that she was not completely out, and we just went on and on and on and on, literally 5 hours in the cath lab, and this woman made it, and I'm not kidding. 2 weeks later, she comes to my office and said, "How you doing?" I said, "I feel great. I just rode my motorbike, motorcycle." And she turns out that she loves motorcycles, and she has this vibrant life, and it was it was amazing. She was a smoker. That was probably her main risk factor, and she probably has some family history. But amazing. That's when you said, I love this fact that the fact that we can really have tools, because someone like her probably would have died many years ago, never given a cent for her life. So that was one. That was the first one that came to my life. I've had the privilege of so many memorable moments. I can tell you some others, but that one for some reason just came out to my mind right away when you asked that question.
Do you still in touch with her?
No, it's been a no, it's just that kind of free life where she's like, if I don't need to see a doctor, I don't need to see a doctor. And so I don't think I saw her maybe 2 or 3 times after that, but I haven't. I'm sure she's doing well around. I hope so.
Wow.
Wow.
All right,
That's
I'm
great.
going to break protocol
great.
and I'm going to ask one more rapid fire, and that is, with all the wearables out there, all the tech and all that, what's your favorite and why?
At this point, the CGM, the glucose monitor,
Hmm.
because it really allowed me to see what my lifestyle meant, at least in terms of the sugar level. Right? It's probably limited to that, but if I learned a lot about my life, my daily life, wearing that device. And I'm not recommending that everybody wears one because we don't know whether it's cost effective, whether it's is the right thing. So I don't want to be sound irresponsible just saying yeah. But I have to admit, I wore it, had it for 2 months, and it really taught me a lot about what I was doing with the stress, what I was the effects of exercise, the obviously effect of food. Because it's not just food. Fascinating enough, it really is. I told you I was really amazed at how the sugar level goes down with exercise.
Mm.
Amazing. And I remember I was doing Pilates. I wasn't doing like heavy cardio,
Mm.
respiratory, long marathons. It was literally all mental.
Oh, I
Mm.
love it.
The power of the brain.
Wow.
Yeah.
Thank you.
All right. Before we wrap up, can you please share your experience with going to the chiropractor and why? And I have you tell all my interns that's the knee
Yes.
problems. Sorry, could you just share this before we end?
Yes. Well, I'm going to share my experience because you know it well. So I was practicing cardiology, and you always try to do this exercise over the weekend. It's like, yeah, I need to exercise, but I don't have time during the week. So I started shooting some baskets in my driveway, and the next day my knees were like swollen, and it's like, oh man, and this is not good. So I went to a orthopedic surgeon, and I'm not, please, this is not the experience for everyone to go who goes to an orthopedic surgeon. So please don't take it that don't go to the orthopedic surgeon. But I had X-rays taken, and he said, you're close to needing knee replacement. And I'm like, what? I'm in my 40s. I always exercise. Knee replacement? No way. So yeah, maybe at most in a couple of years you're gonna need at least one. And then he said, don't ever use stairs because you need to preserve those knees. Don't do anything that could put pressure on your knees. So I said, okay. I used to go use the stairs in the hospital and so on. And then after 3 months, I was feeling like an old man because all I did was just barely, walk, but nothing, no running, no shooting baskets, no exercise, no stairs. And I said, this is not possible. So my wife is the one who led me to you, Dr. Barron, and said, hey, just come to, I was at that point, I was commuting between Virginia and here. So I went to you, and then you did all the exercises and tests and said, your knees are healthy. Actually, let me give you an exercise prescription, exercise regimen. And I started running the treadmill, X number of minutes, as you said, go fast, slow, fast, slow. And all of a sudden I realized like, wait, I can actually use my knees. And that just blew me away. And it made me think, how many people have had really a lot of things done that they really didn't need because maybe they got the wrong advice. And again, not all doctors will give you the wrong advice. I just happened to be in a situation. I was fortunate enough that I found you that led me to a path where it made me feel healthy. And today, I feel honestly better than 20 years ago
Mm.
because
Oh,
I felt comfortable exercising, free to exercise, knowing that I could do it and that I could have someone who was going to watch after my back and my hips and my knees and so on. I'm going to tell you more. You also remember a patient that we're not going to give details about, but someone who called me. It was one of my cardiology patients, as a matter of fact, and he said, "Hey, doc, I need to ask you a question." He says, "Yeah, what's up?" And he said, "Well, I have hip pain, and they told me I need a hip replacement." And I said, "You realize that I'm a cardiologist, right? You're calling the wrong guy." It's like, "No, I trust your advice. Tell me what." And the guy actually, so I said, "Well, I mean, I don't know anything about the hips, but all I can tell you is go to see Dr. Barron." And he actually flew to here, and then to find out that he had a problem with the AT band. So no way he was going to need a hip replacement. And you probably know more details, but it's shocking because it makes you think it's like the amount of things that we should do before we commit to major surgeries or major procedures. So I even advise my own patients, even within the cardiology space, that listen, if you have any doubts, any hesitations, please get a second opinion with another cardiologist. At the end of the day, this is not about my ego, it's about your health. That's what really matters, is your
Mm.
health. So I always tell people, get second opinions. If it's something you need to make a big decision or something doesn't sound right, get a second opinion because two brains can think better than one. So you were the second brain, Dr. Barron, and I'm very
Oh,
pleased.
thanks.
Oh, that's
Fortunate,
awesome.
really.
Thank you for sharing. I love that story. And just in as a final note, I want to give you an opportunity as a cardiologist, innovator, advocate for health equity. And do you have any advice for any aspiring healthcare professionals and those looking to make a positive impact on the future of healthcare?
Yes, the advice is healthcare is where we have a massive opportunity to help people in many ways. Don't think that the only way to do it is by becoming a doctor. In fact, think twice about becoming a doctor because today, with the help of technology, information, everything we've talked about during this podcast, you can actually be part of a team can make the difference in people's lives. So when you think about healthcare, don't think I'm going to have to spend 15 years of my life to become a doctor. No, doctors can be there to supervise a lot of things that we do, but everybody has a role to play. And I think that's another opportunity that we still have within the healthcare space, which is how much burden can we take off the doctor's hands and put it in the hands of others who, well trained in the right hands with the right knowledge, can really make a difference in many people's lives.
Mm.
That was sensational. Thank you so much for being on our podcast. That was, bar none, one of my favorite ones. Thank you.
Thank you.
Thank you,
Thank
Doc.
you.
I appreciate you.
I appreciate the fact that you invited me to be part of it. Very, very grateful.
Thank you for listening to today's episode of the Cracking Backs podcast. We hope you enjoyed it. Make sure you follow us on Instagram at Cracking Backs Podcast. Catch new episodes every Monday. See you next time.